I will speak about what we are doing in like using definitive radiotherapy in locally advanced head and neck cancer without using surgery. And I would like to discuss a little bit the contribution of new treatment techniques such as IMRT, 3D radiotherapy, etc. on the outcome of our patients, and if there is something negative or positive, to show it. Again, this is our hospital, and this is the Leman Lake or Geneva Lake. So in locally advanced head and neck cancer, of course, we have three major modalities: the surgery, radiation therapy, and chemotherapy. And the poor patient is among this. Of course, we were deciding which treatment that we will give to the patient up in a multidisciplinary committee, which is a very key issue in the treatment of head and neck cancer. So, probably you all know the meta-analysis of the MAC and C collaborative group, which is from Institut Gustave Roussy in Paris, and they made their first publication in Lancet in 2000, and then they are doing some update on their papers. So the last update looking to the effect of chemotherapy in locally advanced head and neck cancer was published in the Green Journal in 2009, again by Pignon. And when you look here, the old analysis was about 15,000 patients, and now they have more than 17,000 patients in the meta-analysis. And here, when you look to the effect of chemotherapy globally, of course, it is positive. There is a significant amelioration using chemotherapy compared to radiotherapy alone. But if you look separately, the different type of chemotherapies that we use, adjuvant or induction or concomitant, you see that the best effect or the effect of chemotherapy comes using concomitant chemoradiotherapy. So this is the situation using induction chemotherapy versus control. So there is no significant difference. However, don't forget this induction chemotherapy in this meta-analysis contains very few patients who received TPF chemotherapy. Most of the induction chemotherapy patients in this meta-analysis were they were platinum 5FU patients and without Taxotere. So we will come to this issue a little bit later. So when you look to the effect of adjuvant chemotherapy, again, there is no contribution of adjuvant chemotherapy in head and neck cancer, locally advanced head and neck cancer, and it's even worse. It's not significant, of course, hopefully, it's -1%. The black curve is adjuvant chemotherapy, the gray curve is radiotherapy alone. So, however, if you look concomitant chemotherapy versus control, here you see the patients who receive concomitant chemoradiotherapy do much better than the patients who are treated with radiotherapy alone. So this is a very recent paper, again from the same group, from Gustave Roussy, published by Blanchard in the Green Journal in 2011. They looked again in the meta-analysis among all these 17,000 patients. The differences, the outcome according to different anatomical site. And you see that the contribution of the chemotherapy is significant for even in the different sites, even in the oral cavity, oropharyngeal cancer, laryngeal cancer, hypopharyngeal cancer. Of course, when you have all of them, we know that the p-value was already significant. So these are the survival curves according to the tumor site. The blue curve is radiotherapy plus chemotherapy. The green curve is control. And here you see for oral cavity, oropharyngeal cancer, laryngeal cancer, and hypopharyngeal cancer, the blue curve is superior to the green curve. So let's return back to the induction chemotherapy issue. So this is the induction chemotherapy curves and the Pignon's meta-analysis when you put all together the induction chemotherapy patients. However, if you look separately the curves of the induction chemotherapy, the white curve, survival curve, is the all of the induction chemotherapy patients that you see here. The blue one is the platinum 5FU patients, and if you look at the patients who receive TTF, taxotere, platinum, and 5FU, you see there is a big difference in terms of effect. So probably we shouldn't judge that induction chemotherapy is not good by looking to this meta-analysis, because the induction chemotherapy of nowadays is not the same induction chemotherapy that we were doing in the past. So we have a level 1 evidence showing that the TTF induction is better than the PF induction, and this is the TAX 324 study published in New England in 2007, where the TTF was significantly better than PF in terms of overall survival. So, just let's make a full stop on the chemotherapy situation, and let's look for the fractionation. As Professor Kutan asked me a question on the end of my first talk, what's going on with the altered versus conventional fractionation? So this is a paper published by Overgaard in the Lancet in 2006, and they just make a Cochrane analysis recently also showing these data. So when you look in terms of different altered fractionation compared to the conventional fractionation, this is the hyperfractionated patients, big difference. Accelerated fractionation without total dose reduction, no difference. Accelerated fractionation with total dose reduction, little bit difference. And when you put all the three groups together, there is a small difference in terms of this issue. And you know that also recently, the Swedish group published the phase 3 randomized trial, a big trial comparing altered fractionation versus standard fractionation, and there was no difference at all between the two arms of that study. And when you look again this altered versus conventional fractionation in terms of non-cancer deaths versus cancer death. So, as you see here, when your treatment is a little bit more aggressive, you're increasing also your non-cancer deaths. So probably there is a competition between the complication rate and the control of the disease that you obtain in terms of the aggressivity of your treatment. Anyway, let's continue. So, again, the group from Gustavo C., the MAC analysis group, they published very recently in Journal of Clinical Epidemiology, probably a paper that you didn't see because no one of us they are looking to the epidemiology journals, but I found the paper when I did my PubMed analysis. They looked what happens in the situation that you use altered fractionation plus or minus chemotherapy. So when you use altered fractionation, these are different studies that use altered fractionation. Altered fractionation, just to remember, hyperfractionation or accelerated radiotherapy. As you see, when you put all these patients together, you have a significant p-value. We're showing that altered fractionation plus chemoradiotherapy, I mean the chemotherapy and altered fractionated radiotherapy, is better than the altered fractionated radiotherapy without chemotherapy. And this is the survival curve according to this. So you see here, this is the altered fractionated radiotherapy combined with chemotherapy, and this curve is the altered fractionated radiotherapy without chemotherapy. So the chemotherapy puts something significant when even if you have altered radiotherapy. So, what about targeted therapy? So, I think you all know the famous publication in 2006 of Jim Bonner on the cetuximab Erbitux, where they compared radiotherapy alone. In this radiotherapy, there were hyperfractionated patients, conventionally radiotherapy patients, and some accelerated patients. Most of them were hyperfractionated radiotherapy. They compared radiotherapy alone versus radiotherapy plus Erbitux. And in this publication in 2006, the primary endpoint, the local regional control, was significantly higher in the combined treatment arm compared to radiotherapy alone arm. Here you see, and the median survival here, you see the difference, doubled between 15 to 24 months. So they updated their results. They published their 5-year results in Lancet Oncology in 2009 from this series. And you see, if you look to the overall survival, the Erbitux plus radiotherapy patients did much better than the radiotherapy alone patients, as you see in these survival curves. RTOG did a big phase 3 study comparing a very important question, chemoradiotherapy, concomitant chemoradiotherapy, which is the actual standard treatment, versus the same concomitant chemoradiotherapy plus Erbitux, because the Bonner study was without chemotherapy. It was comparing radiotherapy plus Erbitux versus radiotherapy alone. Here we are comparing chemoradiotherapy plus Erbitux. And here you see the design of the study. It was the radiotherapy was not standard fractionated, but it was accelerated fractionated plus cisplatin versus the same chemoradiotherapy plus Erbitux. And this study was presented in the last ASCO meeting, and it was negative. So we learned that probably when you put Erbitux or when you put concomitant chemotherapy, you are killing the same cells. So you cannot obtain double kill by using the same effect. So we are increasing let's say we are increasing the outcome. We are getting a significantly better outcome in locally advanced head and neck cancer when we put either concomitant chemotherapy or anti-EGFR targeted therapy, and we ameliorate the outcome. We have a better survival, we have a better disease-free survival. But we are dealing with the local regional control. We are not dealing with the metastatic disease. When you look to the concomitant chemotherapy studies, or when you analyze the Bonner study, the effect on the survival that you obtain by putting these two drugs, they are not coming by the killing of the metastatic disease, but this amelioration of the outcome comes by increasing the local regional control effect of radiation therapy. So we have some other studies, interestingly, using the combination of the TPF and cetuximab. This is a French study, Trampin study, phase 2 study done by Lefebvre, which was published, presented in ASCO 2009. This is, of course, it's not a phase 3 study, it's not a direct comparison, but it has a radiotherapy plus cisplatin arm versus radiotherapy plus cetuximab arm after 3 cycles of TPF. So the responding patients, they are randomized like this. However, the non-responding patients goes to total laryngectomy plus postoperative radiotherapy, and those are the primary endpoint is the laryngeal preservation 3 months after treatment in larynx and hypopharynx cancer patients suitable for total laryngectomy. So instead of doing laryngectomy, you are putting the patient in the study. One arm, he gets 3 cycles of induction plus radiocisplatin. The other arm gets 3 cycles of induction plus radiotherapy cetuximab, and only patients who have partial response or complete response. And when you look here, adding cetuximab to radiotherapy provides similar efficacy to concomitant chemoradiotherapy, as you see here. And more patients were able to complete their cetuximab plus radiotherapy course compared with patients receiving chemotherapy. Don't forget that this regimen, this treatment is a toxic treatment. After doing 3 cycles of TTF, you continue with concomitant chemoradiotherapy with platinum. So not all the patients can get the platinum during their concomitant time. However, patients after the TTF can easily get radiotherapy plus cetuximab. So this is a logical combination because here, here you are killing probably the metastatic disease, and here you are increasing the local regional control. And here, as the induction plus the concomitant chemoradiotherapy, it is not easily done because the complications related to chemotherapy increase, of course, so the half of the patients nearly cannot get their treatment. So let's now put apart the effect of the question of chemotherapy, accelerated fractionation, etc. So let's look what's going on with the novel technologies in radiation oncology for head and neck cancer. So actually, from all this long list of novel technologies, for the head and neck cancer, which interests us, of course, is the IMRT, VMAT, tomotherapy, and for the very rich people, the protons. So, of course, all of you know the concept of intensity modulated radiotherapy. It is practically irradiation with tones of gray instead of black and white irradiation, as you see it here. This is an explanation, an example of 2D radiotherapy, which is a simple black and white irradiation. 3D radiotherapy is a complex black and white irradiation, and IMRT, intensity modulated radiotherapy, it's an irradiation using fields of tones of gray. So IMRT is increasingly used. This is an old slide. It was published in 2005 in Cancer and shows in 2004 in the United States 70% of the patients with cancer, they get IMRT. So in Lausanne, we have 2 tomotherapy units and 1 Electra and 1 Siemens Primus. So we are treating all of our head and neck patients with IMRT using tomotherapy. And we are trying to do some VMAT also, but we are not very happy with the VMAT, so that's why they are all treated with tomotherapy. For those who do not know what is tomotherapy, tomotherapy is a new concept of delivery of dynamic conformal radiotherapy, like a CT scanner. This was the first paper published in Medical Physics in '93 by Maki. As you see, this is the description of the machine. It's simply a CT scan, and instead of a 250 kilovolt diagnostic X-ray, you just take it out, you put 6 million volt linear accelerator, and you are turning on the patient, and you're moving the table, and you're irradiating the patient. So the principle: rotate a linac around the patient, mix between a CT and a linac, patient table moving during irradiation, leaves moving during irradiation. It's a native IMRT machine, so it is not done to do 3D radiotherapy or 2D radiotherapy, and it's a native IGRT machine. So simply, you have your planning CT, you can have the tomo CT. This is an example of the prostate cancer patient. Instead of making a setup according to the body structures, you make your setup according to the PTV, which is the prostate, which can move every day. So you do your tomo scan every day, and you make your setup of the patient according to the everyday CT that you do the treatment. So this is an old slide, excuse me, which was analyzing the situation of our patient in 2010. So we had about 1,200 patients in the beginning of this year. Probably end of this year we'll have about 1,500. And as you see, most of the patients were head and neck patients. Probably we should be around 400 patients today. So this is a comparison of IMRT, VMAT, Rapid-ARC, tomotherapy dose distribution for different head and neck patients. Here you see the dose distribution for IMRT, rapid arc, and tomotherapy, they look quite similar. But when you look in the detail, when you compare the tomotherapy to VMAT or to rapid arc, as in the VMAT, you're just passing only 1 or 2 times around the patient. I don't want to go to the inside of the details, but with tomotherapy, you can have a very homogeneous dose distribution compared a little bit inhomogeneous dose distribution using the VMAT. So, a German group published in Strahlentherapy in Oncology last year a paper comparing dosimetrically the dynamic variant IMRT versus tomotherapy and variant rapid arc treatments for exactly for the same patient and very good dose distribution. And they used different situations for dynamic variant IMRT using 2.5, 5 millimeter, 10 millimeter, and in tomotherapy 2.5 centimeter and 1 centimeter collimator. So these two patient 1, patient 2, patient 3 dose distributions. And as you see here, tomo was in all the situations superior to the other type of treatments in terms of complexity of the treatment and in terms of dose distribution. And they concluded in their paper, helical tomotherapy plans show steeper DVH for the PTV, and plans appear to be more conformal and more homogeneous than dynamic IMRT plan for all limbs with rapid arc plans. Of course, there is better, which is proton therapy. This is the Paul Scherrer Institute for the proton therapy equipment in Switzerland. Of course, I'm not working here. So this is a huge machine. As you see here, this is a one person. You see all these. And but if you look those distributions, if you see those distributions compared proton to IMRT, as you see, concerning the PTV, you are as well as good with IMRT for the head and neck cancer. But concerning the normal tissues around, of course, you cannot make competition with protons. You don't give anything here using protons, but you give less dose, let's say lesser doses in the normal tissues. So what we can do with IMRT? So this is an example of a patient, dose distribution for the boost area. This is an SIB patient, simultaneous integrated boost. So you give 2.12 gray per fraction to the boost volume, and you give 1.6 gray per fraction to the 52.8 gray per fraction to the elective nodal irradiation in 33 fractions. And this is the example of the elective irradiation, PTV 52.8. So the dose distribution for the blue one, the blue region received 52.8 gray by 1.6 gray per fraction, and the red volume receives 70 gray in 33 fractions by 2.12 gray per fraction. So, and this is in this slide you see the 26 gray isodoses, and as you know, if you don't go over 26 gray on the parotid gland, you can keep the salivary function of the patient. So for example, these patients, you can spare their parotids doing these kind of IMRT and not going over 26 gray. You can also, by doing IMRT, protect the swallowing muscles. So if you don't pass mean 55 gray on the swallowing muscles, then the patient will not have a problem in swallowing after the treatment, 3 months, 4 months, 6 months, 1 year after treatment. You know, in the past we had a lot of patients requiring total laryngectomy with hypopharyngeal cancer because we gave 70 gray on the muscles without doing AMRT. And some of those patients were operated with total laryngectomy because their larynx were not functioning. So if you can give a mean dose not more than 55 gray to the swallowing muscles, then you can protect the swallowing function of the patient. Again, if you are around 50 gray, if you don't go over 50 gray on the laryngeal region, then you will not have of course, neither laryngeal complications, but of course the patient, if has a laryngeal or hypopharyngeal tumor, you need to treat this region. There is no question. So, having the luxury of having 2 tomotherapy machines in our department, we can do some fancy things also. And we are trying also to spare carotids of the patients with T1 laryngeal cancer. Because if you look to the literature, after 15 years, 1/3 of the patients have increased cardiovascular events, strokes, because of carotid wall thickening. So, the fibrosis of the carotid wall, the endothelial part of the carotids. So if you can spare the carotids, if you don't go over 40 gray or 30 gray on the carotids, then probably you will spare these patients from these cardiovascular events 15 years after treatment. None of us are following our patients for more than 15 years. You know, a laryngeal cancer patient after 5 years, when he's cured, there is no relapse, then you don't continue to follow these patients. Maybe some of them, they continue to come to you. But for the secondary cancers, but nobody are looking what's happening in terms of carotids. So, if you look to the generally what we gain with IMRT, this paper was published in Lancet Oncology, and by the team of the Wilfred Dini is a review, the evidence using IMRT, and they show that IMRT, when you do a review in evidence-based medicine, you have evidence of reduced toxicity. And this is a paper by Vincent Grégoire and his colleagues, the oncologists. What did we gain again with the head and neck cancer, showing that in nasopharyngeal cancer or ethmoid serous adenocarcinoma, for example, the technique increased the therapeutic ratio. So this was published in 2007. This is a news and new from Avram Eisbruch, published in the Nature Reviews. Although significant improvement has been achieved, one might argue that that is not be enough, but IMRT reduces xerostomia and potentially improves quality of life. So there is one phase 3 study done by the UK people. This is probably the only country in the world you can propose to the patient a randomized study saying that I want to randomize you between IMRT and standard treatment, and would you like to accept to participate in it? If I was a patient, I wouldn't accept. But they say that if you don't accept the study, we will treat you with conventional treatment, not IMRT. And when they did this trial, IMRT was already used routinely. So, I mean, it was uncool, but they did it. So they did this study, and they published in Lancet Oncology in 2011. It's called Passport study. 94 patients randomized. And here you see the distribution of, this is the conventional radiotherapy and IMRT. And as you see, the p-value is better from dysphagia, salivary gland toxicity, skin rash, dry mouth. And if you look at the xerostomia rates, salivary gland function, this is the conventional radiotherapy, this is the IMRT. And if you look to the lymphoma subjective xerostomia rates, 3, 6, 12, 18 months after treatment, as you see, the p-values are significant in all the time in favor of intensity modulated radiotherapy. If you look to the RTOG subjective salivary gland toxicity superior to grade 2, then again IMRT is significantly better. Is there any difference in terms of survival or outcome by doing IMRT? I mean, are you doing something bad to the patient by protecting his carotids, etc.? No, this is the local regional progression-free survival rate, and this is the overall survival rate between the two arms of the study. So the conclusion of Chris Nutting in this study was IMRT significantly reduced the risk of subjective xerostomia, and these data support the adoption of IMRT as the standard of care in head and neck cancer patients. There was one issue in this paper. It was that the IMRT patients had some increase in the radiation fatigue. And this is probably of that you are giving some small doses in the brain of the patient by doing IMRT, because you are turning around the patient. so you're distributing some small part of the doses around, so the patients have a little bit more fatigue. But this is not very important compared to what you gain by by sparing salivary function. So let's look for different randomized studies. This is a nasopharyngeal carcinoma done by the Hong Kong people, randomized controlled trial. Again, it showed significant benefit of IMRT compared to conventional radiotherapy in terms of stimulated whole salivary or stimulated parotid salivary function. Again, another study from Hong Kong, and here also on early stage nasopharyngeal carcinoma. And again, it showed that IMRT was superior to 2D radiotherapy in terms of whole salivary function, parotid outflow, or grade 2 or 4 xerostomia. Again, randomized study. So what's going on in the literature in terms of retrospective studies? So this is a retrospective, non-randomized, it is a prospective study, but it's not randomized, done by people from Holland, Langendijk and his colleagues, and they look to doing their, let's say, health-related quality of life analysis prospectively in their series, and they show that patient-rated xerostomia, doctor-rated acute xerostomia grade 2 or more, acute mucositis grade 3 were significantly better in patients with, who are treated with IMRT. 240 patients. So, when you do IMRT, do you have a danger doing osteoradionecrosis? Maybe you can put some hotspots around the mandibula. The group from Abraham Ice group looked at, and they show that no case of clinical osteoradionecrosis in these patients. Again, a paper from Zurich showing that there is no, only in Turkish, I'm sorry, that was a slide that I used, I forgot to translate to English, but there was only one case with grade 3 osteoradionecrosis. Is it dangerous to do parotid protection in this region by doing IMRT? Do we have any relapses in this region when you do this parotid sparing using IMRT? There are a number of publications in the literature showing that Abraham Ice group, Clifford Chow, Barbara Bustles from Europe, no evidence that you increase your relapse rate by using IMRT and by doing parotid protection. Again, 3 papers, Taudel, Gabriele Studer from Zurich, people, very important center, William Mendelhall from Florida, no evidence that increased the original failures. So, I have 2 slides of conclusion, what I told here. So we can say that, definitely we can say this, concomitant chemotherapy plus radiotherapy is better than radiotherapy alone in locally advanced head and neck cancer. Superiority of this combined treatment is observed in all head and neck subtypes. We can say, definitively say that induction TPF is better than induction PF. We don't know the induction TPF plus chemoradiotherapy versus concomitant chemoradiotherapy. There is a Spanish study presented in ASCO 2009 by IT, a collaborator, looking to this question. They have no definitive results. It looks that induction TPF plus concomitant chemoradiotherapy is a little bit better than concomitant chemoradiotherapy, but you pay this with lots of toxicity, and they didn't publish their results yet. We are waiting for it. We can say altered fractionation is definitively better than conventional fractionated radiotherapy. We can also say altered fractionated radiotherapy